Very much for a very kind invitation and for Professor Fee for a very kind introduction and to have me here. I have the privilege of already.
Rồi âm thanh kết nối cái mic của thầy với hệ thống âm thanh ở trong đây nha. Lại mic của bác Phi nói được nghe được. Lại cái mic của bác Phi nói nghe được.
Không biết này thì không.
And so today I want to talk about my perspectives in vertical and horizontal reorganization. And I want to show you one thing. That this bone was drafted about 6 months ago. And it sounds like this.
Thì cái xương ghép này ngày xưa tôi đã thực hiện 6 tháng rồi, nhưng mà mọi người có thể nghe được cái tiếng gõ rồi đó. Rồi tôi play lại cái video một lần nữa nhé. Đó, mình biết là vậy là mình biết là xương rồi, và đây là cái khuyết hổng nè mà tôi đã điều trị, nhưng mà thật ra tôi không có thực sự nhớ ca này. Tôi đặt kim plan vào, tôi ngó cái hình rồi tôi tôi không nhớ bệnh nhân này là ai nữa. Tôi thực hiện khoảng những cái live surgery một năm, tôi làm 90 đến 100 cái buổi live surgery một năm. Dĩ nhiên là phẫu thuật bệnh thông thường hàng ngày thì còn nhiều hơn nữa. Thì mọi người có thể thấy ở đây có những cái vách xương ở đây thì có vẻ rất là đơn giản để mà có thể tái sinh được. Nhưng mà cái người này thì tôi nhớ nè. Bệnh nhân này người ta đã được ghép mô mềm rồi, và đó là cái sai lầm lớn nhất mà mọi người có thể có thể phạm phải. Những cái việc mình ghép mô mềm ở đây nó khiến cho cái vạt của mình nó có những cái điểm yếu, và tôi khuyên mọi người đừng có làm như vậy. Thì bệnh nhân này tôi nhớ nè. Thì đây là bệnh nhân đầu tiên của tôi. Bệnh nhân đầu tiên mà tôi điều trị vào năm 1999 ở Loma Linda. Thì tôi đã hỏi bác sĩ Lozada về những cái insight của ông về cái chuyện mà ghép mô mềm, ghép mô cứng theo chiều dọc. Thì bệnh nhân đây là cái ca mà tôi gặp năm 1999. Ngày đó tôi ăn trưa với ông và tôi nói với ông là tôi muốn ghép xương theo chiều dọc, và cái muỗng của bác sĩ Lozada là đóng băng luôn, xịt keo cứng ngắc. Thì tôi nói là ông rất là ngạc nhiên là không ra cái chuyện mà ghép như vậy có được hay không. Thì tôi nói là được. Vậy cả 2 tháng sau thì vẫn là rất là nhiều những bác sĩ khác cũng nói với tôi là thôi ghép không được đâu, đừng có hỏi. 2 tháng sau thì ông hỏi là để tôi chuyển bệnh nhân cho anh nha. Và nếu như mà anh có thể làm được, có thể thực hiện được, thì tôi sẽ trả tiền cho bệnh nhân, mà sẽ trả học phí cho bác sĩ Urban. Lúc đó là tôi nghĩ có vẻ thơm. Tại vì cái hồi đó thì Nobel Biocare thì người ta chưa có thể tài trợ cho một cá nhân được, người ta chưa có chọn tôi. Cái yêu cầu duy nhất đó là phải xuất bản được một cái bài báo cho Zomi. Nếu như mà mọi người có thể, nếu như mà anh có thể điều trị được cho bệnh nhân thì tôi chọn gửi bệnh nhân nhiều hơn cho anh nữa. Đây là bệnh nhân năm 1999. Đây nè, bệnh nhân đây. Thì bệnh nhân tới phòng khám. Tôi khám cho bệnh nhân. Bác sĩ Lozada thì giới thiệu bệnh nhân có rất là nhiều những cái vấn đề về thiểu sản men, ngà và có cái khuyết hỏng xương nữa. Thì tôi quan sát bệnh nhân thì tôi ngó bệnh nhân thì kêu bệnh nhân này đây là cái ca mà tôi muốn nè. Còn bệnh nhân thì gặp thì ngó tôi hỏi tôi là anh là sinh viên hả? Xong rồi hỏi tôi là anh đã thực hiện bao nhiêu ca phẫu thuật rồi? Thì thành thật mà nói là tôi chưa có thực hiện một ca phẫu thuật này như vậy cả, nhưng mà tôi biết cách để mà thực hiện. Thì bệnh nhân nói tôi là ok. Cái cuộc phẫu đó nó kéo dài 4 tiếng. Thì Tôi sau khi mà phẫu xong rồi tôi cũng thảm hơn bệnh nhân nữa. Rồi sau đó thì đây là cái phần xương mà mình đã tái sinh được. Đây là năm 1999 và đây là cảnh tái khám. Đây là 3 cái implant mà tiền thân của Nobel Biocare. Trong cái năm đầu tiên thì tôi tiêu đi 1,5 mm xương viền, và rồi nhiều năm sau đó thì không hề tiêu thêm miếng xương nào. Nhưng mà đó không phải là cái chủ đề mà tôi muốn nói ở đây. Cái mà tôi muốn nói đó là tôi đã rất là may mắn, bởi vì cái phục hình này nó có cái đường hoàn tất bị hở, và nếu như mà cái đường hoàn tất mà hở vậy thì mình biết là nó rất là dễ bị viêm nhiễm đó. Nhưng mà may mắn là tôi đã không có gặp cái trường hợp đó. Nếu như mà ở đây cái trường hợp này mà cái ca đó đã bị nhiễm trùng thì chắc là tôi không có mặt với mọi người ngày hôm nay đâu. Cái ca này đó là cái câu chuyện mà dẫn tới việc tôi có mặt ngày hôm nay nè. Thì ngày hôm nay thì tôi có những cái ca như thế này. Bệnh nhân này có một cái lỗ giò, và đây là cái xương mát mà người ta đặt lên. Người ta ghép vô cái vị trí này bởi vì bệnh nhân bị ung thư. Thì tôi được giới thiệu bệnh nhân tới từ khắp thế giới. Đối với ca này thì bệnh nhân đã 45 tuổi rồi, bệnh nhân nữ 45 tuổi. Tôi quan sát trên phim X-quang thì tôi không muốn điều trị với ca này đâu. Mọi người thấy đây là cái xương mát mà, làm sao mà ghép lên xương mát được? Toàn là mô mỡ không à. Có rất là nhiều những cái mô như là mô mỡ hay là thậm chí là lông tóc móng còn lẫn ở đây. Nhưng mà bệnh nhân năn nỉ thì tôi kêu ok, làm thôi. Bệnh nhân 45 tuổi và đây là cái vấn đề lớn nhất của cổ trong cuộc sống. Tôi nói với cổ là ok, tôi sẽ điều trị cho chị. Bệnh nhân hỏi về giá. Thì tôi tạo điều kiện cho bệnh nhân đó là chắc là tôi sẽ đưa chị vào một cái buổi để làm mẫu cho một trong những cái khóa học của tôi, thì chi phí của chị sẽ giảm được khoảng 3.000 đô. Bệnh nhân thì bệnh nhân ban đầu tưởng là cái chi phí của tôi chắc là 1.000 đô thôi. Đó là cái bệnh nhân mà hay đến gặp với tôi, hay giới thiệu với tôi có những cái vấn đề lớn như thế này. Và đây là cái cách mà mình thực hiện kỹ thuật số. Đây là một cái mẫu thôi. Giờ mình sẽ cố định cái màng đó ở trong cái khung này. Mình sẽ dùng cái prototype này để mà cố định cái màng vào vị trí. Hôm nay tôi sẽ giới thiệu cho mọi người những cái master guide để mà có thể đặt được, cố định được cái màng ghép này vào. Nó còn dễ dàng hơn là cách này nữa. Rồi quan sát ở đây, bệnh nhân đến với tôi mà có cái dây thần kinh nó đã lộ ra mô mềm rồi, một cái khứ họng rất là lớn, và dây thần kinh nó lộ ra là không có xương nó che phủ ở phía bên trên nữa. Nếu mà không có xương che phủ ở phía bên trên vậy thì làm sao mình ghép xương được? Thì đây mình làm một cái bán hướng dẫn phẫu thuật để mà xác định được cái vị trí mà mô mềm nó bị lộ bằng cái phần mềm DTX và chế tác một cái guide. Tôi chỉ đang đây là một cái update mới mà tôi muốn chia sẻ với mọi người. Đây là cái phần hàm trên của bệnh nhân. Bệnh nhân này còn trẻ tuổi hơn tôi nữa. Cổ không có muốn đặt implant gò má đâu. Cô nói tôi là vẫn còn quá trẻ để mà đặt implant gò má. Thì cổ khám bác sĩ ở Ý, thì sau đó thì họ giới thiệu đến với tôi. Thì hỏi tôi là điều trị được không bác sĩ? Tôi không muốn điều trị đâu. Xương nó mỏng như giấy vậy. Thôi làm gò má đấy chị. Nhưng mà bệnh nhân cũng rất là nài nỉ. Ok, chơi luôn. Rồi cổ quay lại sau 2 tuần lại hỏi giá điều trị. 60.000 đô nha. Sau đó cổ 2 tuần sau cổ lại quay lại cùng với lại chồng. Bác sĩ à, đây là người vợ duy nhất của tôi. Thì anh có thể điều trị với cái giá 100.000 đô không? Thì mình thấy là cái xoang hàm của bệnh nhân nó rất là xông lớn rồi. Có nhiều người ta còn cố gắng người ta ghép xương vào cái nền mũi nữa. Đây là cái phần xương ghép mà tôi cố định cái màng bằng tay trái. Và phía bên kia thì tôi sử dụng cái kỹ thuật xúc xích một cái màng collagen co giãn và cố định bằng những cái pin. Và bây giờ làm sao mình làm phục hình tạm. Đối với cái hàm trên thì tôi sẽ đặt một cái 10 và làm một cái overdenture. Đó là cái concept mà chúng tôi gọi là all on one. Sau đó nó sẽ nâng đỡ cho cái hàm giả và mình điều chỉnh cái hàm giả ở vị trí này. Rồi sau đó mình đệm để mà cái hàm giả được nâng đỡ ở vị trí lồi cũ và cái phần hậu cái. Và đây là cái quá trình lành thương nè. Ở đây mình đặt implant được chưa? Cái phần xương ghép của mình nó tựa lên trên cái phần xương nền mà ban đầu tôi nói nó mỏng như tờ giấy rồi. Nhưng mà tôi cũng gặp được những bệnh nhân tương đối dễ hơn. Thì bệnh nhân trẻ nhưng mà rất là buồn bã vì không có cái sự đối xứng của gương mặt. Cô đến từ đất nước khác để mà ghép xương. Thì hỏi tôi là bác ơi có sửa được cái phần môi, phần mũi này luôn không? Không, khó quá, sao mà làm được? Nhưng mà nếu tôi không điều trị cho bệnh nhân này thì chắc là không có ai nhận nữa, cho nên là tôi phải làm thôi. Đây là ảnh trước và ảnh sau điều trị. Và giờ thì bệnh nhân vui vẻ rồi. Đây cũng là một cái chủ đề mà tôi muốn nói ngày hôm nay. Mọi người xem nè, đây không phải là ca của tôi. Bệnh nhân này được đặt 2 cái implant. Và đây là phục hình sau cùng rồi đó. Đặt 2 cái implant và rất là nhiều lần ghép, chắc cũng phải tới 10 lần phẫu thuật rồi. Một bệnh nhân nữ rất là xinh đẹp nhưng mà không có vui vẻ gì. Mình điều trị được không? Mình có tái sinh được cái phần gai nướu mà thiếu tới 5-6 mm như thế này không? Đây sẽ là một cái chủ đề mà tôi cũng muốn truyền tải hôm nay. Mình đã tái tạo được cái gai nướu này. Và đối với ca này thì mình có phải nhổ cái răng này không? Thì một cái quy tắc chung đó là nếu như mà mình mất một răng thì tôi sẽ chết trước khi mà tôi nhổ cái răng kế bên. Thì bằng mọi giá tôi sẽ giữ cái răng phía bên cạnh. Đây cũng là một cái chủ đề mà tôi muốn truyền tải hôm nay. Đây là bệnh nhân được giới thiệu tôi từ bệnh viện Trường học và ở cùng Hàm Sát. Thì đó là một trung tâm cũng rất là nổi tiếng. Nhưng mà đây là một cái khuyết hỏng rất là lớn. Khi mà trường liên lạc với tôi thì anh có muốn nhận bệnh nhân này không? Kêu cứ gửi tôi đi, tôi đưa bệnh nhân vào làm live surgery. Thì bệnh nhân bị ameloblastoma, bị u nguyên bào men. Lúc đó người ta kêu là ôi ông này ở bệnh này chắc chưa biết, chưa thấy quan tài, chưa đổ lệ rồi, cho nên là tôi kêu thôi cứ gửi CT cho tôi coi đi. Thì đây là cái khuyết hỏng nè. Và bệnh nhân tới cái ngày ngay trước khi phẫu thuật thôi, tôi chưa có khám bệnh nhân. Để khi bệnh nhân tới thì trợ thủ của tôi nói là bác ơi, người ta gửi bệnh nhân với lại CT scan tới rồi, bác ngó qua được không? Cái tôi thấy là người ta loại bỏ luôn cái nền mũi rồi. Nếu như mà tôi coi phim CT trước thì chắc là tôi không nhận rồi. Nhưng mà giờ bệnh nhân người ta lỡ tới rồi, mà ngày mai là lịch mổ của họ. Nếu như mà tôi muốn đặt implant đây á thì sao mà làm được? Sao mà đặt implant trong không khí?
1, 2, 3 implants. These are the N1 implants. They're not in Vietnam yet, but I think they're coming. This is the first time in the history somebody connected this with the normal bone graft and membrane. That's her face, which was distorted. There was nothing in here. Prosthetically placed restoration. Here's the bone. These are the permanent abutment. The N1 implant has an abutment that you have to never remove. Very good connection, so I love it. Cortical bone here. New soft tissue graft. And here it is. Okay, so this is also one I want to talk about. Okay? I also do small cases. It's a single tooth. But there's no palatinal bone, there's no buccal bone. Can I extract, put an implant, a bone graft, and there's a recession and a soft tissue graft? Today I say there is no tooth on the planet that I cannot take out, put in the implant and regenerate in one session, one shot. I extracted this, I put in the implant, I put in a bone graft, microsutured, put a soft tissue graft, made 2 vertical incisions, microsuture. Here's a microsuture. Here's the bone graft. Couple of years later, here's the bone graft. This is also the N1 implant, N1 abutment. It's perfect. What about this? This patient is a dentist. Is a very thin phenotype, recession, 12 millimeter pocket, high smile line. Can I make a flap? Put in an implant. That's a noble active. For extractions, I usually put a noble active. It's very stable. But now I need a bone graft. I need a soft tissue graft at the same time. I need a bone graft. I'm going to take the bone from here. I do a biomaterial with the bone graft in conjunction, a mixture, and I put a layer. Then I make a membrane. I'm going to make a membrane. I'm going to talk about this in the afternoon, okay? How exactly I do it. Now I need a soft tissue graft. Then I need to coronally position the flap. Then I need to suture. And here's the crown. Without a smile, no smile. Here's the with a smile. Here's look at the vertical incision. The vertical incision disappeared. I use a microsuture technique to disappear the vertical incision. Look at this patient. This patient has these 2 implants. There's no bone in here. There's very little bone in here. There's not a papilla should be here. There's no papilla. So I'm going to put in 2 implants. This is 1 implant, this is 1 implant. I do a papilla graft. That's a papilla graft. There is no mucogingival distortion. What I did is called mucogingival rebounds. I move and let it go back. And so she has these beautiful teeth now with 2 implants and bone and soft tissue reconstruction. This is also my topic in the afternoon. This patient doesn't have any papilla, 0. And this tooth, the lateral incisor has no bone. It's the root. I will regenerate the bone here, then I will regenerate the soft tissue for a papilla. You want to see that? The papilla down here, regeneration on here, such as this. Now I'm going to put a crown on this parallel CC. Bone is reconstructing the root, here is the implant and the bone, and here is the papilla and the crown on the implant. I'll talk about these steps in the afternoon. This is an implant. And this patient didn't have any bone on the buccal. There was no bone on the buccal. There was vertical incisions. And as you can see here, same thing. This patient had bone graft, implant placement, bone graft, soft tissue graft. 1 implant, and here's the other one. And no mucogingival change. Here's 1 implant, here's the other implant, this is the pontic. This patient has very small maxilla, very minimal maxilla. Easy, all on 1. Then bone graft, then at least 6 implants. 1 implant in the middle, some scraping for the bone, mixture with the xenograft, 2 collagen membranes, some pins, and here is the new maxilla. Why do we need bone? What if you put an implant to narrow bone? What happens if you feel like you can put an implant here maybe, but it's very thin bone? What happens then? It's very interesting. So I get a lot of patients who had implants, then they failed. And when the patient comes, the patient is asking me, doctor, how can you make this? How can you make this regeneration better than my own bone? It's a good question. But this bone was very thin. When they placed this implant, the bone was so thin. If you place an implant to a bone plate which is less than 1.5 millimeters, the bone will resorb. The bone resorbed here on the buccal, on the lingual. On the lingual there was no keratinized tissue, difficult to clean, rough surface, bacteria, and then peri-implant disease. In this one, I'm going to regenerate this very high and wide. Then I put good keratinized tissue. Then I'm going to make the patient to clean this, teach the patient to clean this, and I can prevent that this is going to happen again. So, put an implant to narrow bone, what happens? What happens? If you put an implant to narrow bone, you're going to lose bone. In 5 years, it's in the 2nd thread. Why? Avascular necrosis of the bone. This black line is a publication we have done. The black line is regenerated bone, which is white in the same patient. This is narrow native bone. This is what happens. You put an implant in to less than 1.5 millimeter of bone, you're going to have this. So if you put an implant to very thin bone, you're going to lose the buccal bone. This is my implant. My mistake. I placed this implant and I lost the buccal bone in the first day, first couple of months. Then, in 5 years, the bone will follow. So today, especially in the posterior mandible, posterior maxilla, if I place implants and the bone is very thin, I do a mini sausage to widen the bone. This has been supported in a very important study in a Swedish university by Wenström and Linda. They found the same thing. This is not the fault of the implant. It's not the fault of the implant. It's my fault. My fault. Sometimes it's easier to place an implant, put a healing abutment. Patient comes back next week, doctor, you're the best in the world. But 7, 8 years later, okay? Especially in the posterior mandible and maxilla. Mandible is the worst. You put multiple implants in narrow ridge without the bone graft, you can have a problem. This is from my study. Wide bone in 10 years. Same patients, narrow bone in 10 years. There is more chance that you will have periimplantitis on this implant. Isn't that true? So we need techniques that are less invasive, because we need to do more regeneration than we thought. And for bone regeneration, we don't want to be very extensive. We want to be gentle. We want to be less invasive. And so, look at this patient. This patient has some good teeth, good implants, but this is missing the posterior mandible. Why? Somebody put in 3 big implants in a narrow ridge. Then there was no good tissue. Patient was not cleaning maybe well and lost the entire posterior mandible. And now the patient doesn't want to have an all on 4, because the patient says, look, these are my own teeth, they're 65 years old, I want to keep them. Find somebody to regenerate. Find somebody to regenerate this. This patient was sent to me from the University of Graz in Austria. They call me, Istvan, can you do this? I look at my phone, no glasses, not sharp. Can you do it? Yes. Are you sure? Yes. But 2 things went through my mind. Number 1, this is a lot of cortical bone. Is a very poor host to connect to a bone graft. Okay, see this bone? Difficult. And mental nerve is here, my incision is here, so the flap is very short. You have a 3-4 millimeter flap, and you want to put a 10 millimeter bone. You want to put this bone graft in here with this flap and close. Can you do it? Yes. Are you sure? Yes. Okay? And I show you why. Because we have the technique how to make this 3 millimeter flap 15 millimeter long without damaging the nerve. There it is. Look at this patient. Had a chin graft, ramus graft, everything failed, and this is the defect. So now I'm going to regenerate, but I want to understand how the bone will form on this mandible. And I want you to understand it too. Because it's very important to understand what you do and how you do it. In the literature, we can say that every technique, all the techniques, similar in terms of vertical gain, but techniques using membranes, this type of membranes, have the least amount of complications today. If you look at the membrane technique versus, for example, bone plate, bone block techniques, much less complication. According to the literature, you can only regenerate 4 millimeters. Not true. You have to regenerate this one, 10. Can I do 10 here? Let's take a look. It's the same patient. Let's take the membrane out. And now I have a new mandible. Cortical bone, 10 millimeters. So yes, I can regenerate more than 5. Now, let's take a look at this one. It's a very old case of mine. Here's the defect. Here's the bone graft. 16, this is 20 years later. These are standard Brennermark implants, long time ago. What do we know about this? We published a paper with Dr. Kupke, and we found guided bone regeneration, the blue line, is the most well documented and the best bone. There are some techniques, I don't want to list them, which have no publications. Very popular techniques. Yesterday we were talking about the technique, this or that. One has no publication. Ooh, look at this defect. I want to put an implant, but the implant will be shorter than the defect. 100% regenerated bone. Can I do it? These are 3 N1 implants with the N1 abutment. Look at this perfect bone around them. Even though the defect was bigger than the implant. 100% in regenerated bone. Still works. What is this implant here? Somebody put an implant from the side. Where? To the nerve. So the patient has paresthesia. So I removed the implant and the paresthesia started to disappear. But I have the defect. There's paper pin here, there's a hole here. I want to put an implant here. She's young. Can I put an implant there? Yes. Here's the bone. 4 millimeters is not the limitation. Can I put an implant here? An implant here, an implant here. Yes. An implant here, an implant here. So, first before you do a bone graft, you have to look at the factors that influence your result. So first I want to teach you how to look at the patient before you do anything. Okay? The most important factors. Number 1, the angulation and the narrowness. So for example, this patient, you cannot do an all-on-4 because this patient is very, very thin. Very, very narrow. So you're going to have to do a bone graft in here and here. What will I look? Number 1, the width of the basal bone. Is it wide? This one is wide. But it's not always wide. Not always wide. Sometimes it is very thin. Why is there a problem if it's thin? It's a problem because you need a balloon. If you put the bone graft from here, it's not good. You have to go all the way down to incorporate all the biological information. Number 1 is the width of the basal bone. Here's the newly formed bone here. I'm putting in 3 implants. These are replaced, this is a parallel, and it works pre-functionally. The second and even more important is the angulation of the bone. The angulation of the bone behind the last tooth. Why is that important? Because it can be an angulation which is not very steep, this is more steep, and this is extremely steep. This is much more difficult than this because of 3 reasons. Much more difficult to fixate the bone graft. This has more biological potential to have the bone formation. So this is very difficult to fixate, and this, I want to treat this patient over that patient. But what if you get this patient? What if you have this patient? What is the problem with this? 3 things. Number 1, slower bone formation. This is faster than this because the bone will form from here and here and here. From here, it's only from here. Number 2, the bone graft will touch the root. Why is that a problem? It's not a problem as long as this tooth is very, very clean. And if this tooth, you change the filling and the crown. If you have a filling which has a gap, bacteria, you need 3 things to get bone. 3 things. You need a good graft. What is a good graft? Good graft is, let's say, 50% autograft and 50% xenograft together. Okay? This good graft should not move. So that's why you need the membrane to immobilize. And there should be no bacteria. So you need a closed flap. These 3 things you need for a bone graft. Okay, so that's why the tooth has to be very clean. And you have to change the filling, you have to change the filling, you have to change the crown. You have to look at the bony peak. If the bony peak is reduced here, the nerve is here, you have to sacrifice this tooth. The canine is the queen. The premolar is the pawn. In chess, sometimes you do the pawn sacrifice. In bone regeneration, sometimes you do the pawn sacrifice. And then it's going to be easier to fix. Higher bone formation, higher bony peak, and much more bone. You can see here the 3 different implants. It's from a randomized clinical trial. Look at this bone. What about this tooth? This patient sent to me from Austria. There's a radiolucency here, bony peak down here, bony peak here. Don't do a new root canal on this because the bone is going to be this. Take the sucker out and regenerate it all the way up here. All the way up there. Okay. What is important of this picture is that you do a bone graft, the bone graft is healing, there's a membrane, see there's a titanium reinforced membrane here, but the soft tissue is very thin. With titanium mesh, you have a 25% chance, 25, that during the healing this will be exposed. What is good with the membrane is soft and the soft tissue does not move. Because the bone graft and the soft tissue, the bone graft will osseointegrate with the bone and the membrane, and the soft tissue will also have some osseointegration over the membrane. It doesn't move. It doesn't move, so that helps a lot. Soft tissue grafting before bone grafting. In this one, not possible. I never do a soft tissue graft before a bone graft. I always do it after. And in this particular patient, the nerve is here. So you do a soft tissue graft, you damage the nerve very easily. No soft tissue graft necessary. Anterior maxillary patient is my favorite. Look at her. She looks like this. She comes like this. She's from Poland. She doesn't have a job. She doesn't have a boyfriend. She doesn't go out of the house for the last 10 years. She was in a coma, hit by a car. Somebody did a hip graft in here that resolved, so she doesn't have any bone and teeth here. This patient is a dentist. She's a flipper. Her maxilla is in 2 pieces. This patient has a defect here. She's from Switzerland. The dentist created the defect. So, all these patients, she doesn't want to look into the camera. They're very unhappy. Look at this patient. She's 50 years old. 20 years ago, she had an accident. Somebody took a chin graft, took a ramus graft. How do you put a bone graft in here? There is no way you can do a bone block, because there's not enough bone in the mouth. So the advantage of what I'm doing is, I'm taking some bone, but if I particulate, the volume grows. If I mix with a xenograft, the volume grows, and all of a sudden I have enough bone. So it's very easy. I take a scraper, I have volume. See, I curl my hair like Jimi Hendrix. I have a lot of hair. This is what happens with the bone. So I have a very good graft now. I have to immobilize. Okay, I use a membrane to immobilize. Then I need a soft tissue advancement to close the flap. I advance the soft tissue, and then I go to the lower jaw, and even the lower jaw has enough bone for the same patient. How much bone I got? It's an amazing amount of bone I got. And much easier because I don't have to shape anything. I just fixate, fold the membrane, fix it, and I'm done. Will I get any bone here? Here's the bone. Here's the upper jaw. I'm just opening it up before I'm going to put an implant. Remove the membrane. And all of a sudden, I have 15 millimeters high, 6 centimeters long, and 1 centimeter wide bone, with a much less invasive approach than anything before. And look at the face of the patient. Face of the patient before, face of the patient after. Patient is telling me, doctor, don't rush. Keep my bone like this, okay? Because I love my face. Look at her face. Yeah? See, there's a huge difference. So for the anterior maxilla, you can make the patient's life very big change for the anterior maxillary bone grafts. Okay, let's talk a little bit about how this bone is going to form. Here's a bone graft. I'm going to do the bone in here, from here to here, using a particulated bone graft. All particles. But which one shall I use? I have the full autogenous graft. I have the mixture with autogenous and the xenograft, layer, allograft. So who's using full autogenous bone graft? I used to use full autogenous bone graft, but I don't do that anymore. And the reason is this. This is a 15-year follow-up, full autogenous is good. This is 13 years, it's thin, but 2 threads exposed. Look at this. 15 years, the bone disappeared. Bone is here. In case you have a patient with a thin phenotype and you put an autogenous bone, it will shrink. Autogenous bone is not protected against genetics. If you make a mix with a xenograft or a layer with a xenograft, it cannot shrink. Okay? So that's why we don't use 100% autograft anymore. See this resorption? This had bone all over the place. But we still use some autograft, and we use autograft. There are 2 types. One is a cortical bone. This is cortical. And here's cancellous bone in here. Cortical bone has not much of biological cells. Okay, it's only osteocytes. Here, you have osteoblasts, which helps bone formation. So, what if I'm going to scrape, just scraping? Scrape, scrape, scrape. What's dead? Is dead? Maybe not. Because when you scrape or particulate, scrape, you will get 43 different growth factors in the extracellular matrix, such as TGF-beta-1 is a very important growth factor. How important? Well, let's see. TGF-beta-1 is important, but it doesn't produce any bone. When you scrape bone, there is some BMP2 in your bone graft. And BMP2 alone is not very effective, but together these two will form a lot of bone. So, this is what happens. When you scrape some bone, in 10 minutes, the TGF-beta-1 is coming out. Then in 40 minutes, up to 6 days, the BMP2 is coming out. The TGF-beta-1 is collecting the BMP2 to the site. Okay? So the TGF-beta-1 is a policeman. They do work together really nicely. This is my first article, and with my first 36 cases, and we looked at the implants. Those implants were predominantly Brennemark type of implants, and we found that the anterior maxilla, the posterior mandible, and the posterior maxilla was equally like native bone. And so this is a very important paper. It's still today showing that if you regenerate bone that is wide enough, see? Wide enough. How wide? You have a 4 millimeter implant, you want to have 2 here and 2 here. That's 8. That's 8. Look at this patient. I was treating this patient when I was 32 years old with one assistant in a one chair dental office. And here is the patient. Patient passed away in a stroke 12 years later. These are my implants. There's something funny on the x-ray. See this? I put some biomaterial, some BIOS with a collagen membrane on top of the bone graft when I place the implant. A mini sausage. I do a much better mini sausage today, but it prevented any bone loss. How much bone loss do you get if you don't put a mini sausage? You can get 2 millimeters of bone loss. I want to talk about these 2 millimeters, how to prevent it. And we published 3 papers. This paper is for the mini sausage, completely preventing this, But mini sausage is just a technique. I want to understand the biology of it. So, when I do a bone graft, I'm going to place the graft, and this is the host bone, this is the grafted bone. First, it's not the same. This bone graft is different than the host. This is the first phase of the bone formation. It's beautiful and red. But there's no cortical bone. There's no cortical. This is the phase 1 called the baby bone. Phase 2 is when the cortical bone will grow on top of this. It's a phase 2. This is beautiful, but it's not the final bone. Between these 2 phases, there is a change. Let me explain this. It's very, very important. Boring, but important. This is a bone graft of the first day. This is a bone graft at 11 weeks. You see this green is a baby bone. No cortical bone, no Haversian channel, is a baby. 17 weeks later, you see the Haversian channel and you see the cortical layer. Between these 2, there is a change. This is the baby bone, old bone, new bone, and in the surface is something interesting. In the surface we have found something that researchers think that this is the most relevant finding in the last 10 years. It's going to be very interesting. when you do a bone graft, first, you will find that the collagen fibers will grow into the bone graft. Periosteum is moving and will get fixated by itself, like this. Why is this important? Well, let's take a look at this. This is an old mandible and a new mandible I regenerated on an animal. Let's take a look in here. There's a little white something. So I called Dr. Peter Schubach, who was one of the leader, he's retired, one of the leading histologists, and I asked him what he thinks. He said, we need bigger magnification, better microscope. Bring it to Zurich. So I brought everything to Zurich. He's retired, but he's looking at it. He said, Sharpie fiber. Actually, first he wrote Sharpie fiber, and now we call it sharp. It's Sharpie-like fiber. Sharpie fiber is not only in the teeth. Sharpie fiber there's other places. And we believe when you do a bone graft, sometimes when you don't use a membrane, like a Curie type of technique, it's full of Sharpie fibers. When you do a membrane, which is not perfectly adapted, 30% of your bone graft has Sharpie fibers. Why is this important? Because if you put an implant here, doesn't matter which brand, the final bone will be here. What happens to your implant? Bone loss. So you have to put maybe the implant deeper. Okay. But what if I don't want to put the implant deeper? In the anterior, I don't want to put the implant deeper. So then I take a curette, I refresh, the curette. Then I put the implant here, and I do a mini sausage. In the posterior mandible, I put the implant here. Anterior maxilla, I put the implant here, and a mini sausage. I'll explain this later, okay? But this, remember this, because if you don't know this, you will have bone loss. This can be such a big problem that some people went back to machine implants because they didn't understand this. And a lot of people putting the implant deeper, but they don't understand why. This is a phenomenon for bone regeneration, and when you do it all on 4 and you cut the maxilla or the mandible, we did it in the animals, the control group, we found the same thing. Sometimes there is Sharpie fibers. And some all on 4 is perfect, some all on 4, one implant is bad, right? Why? Very likely because of this. Okay? Very likely because of this. This is a phenomenon which is maybe one of the most relevant findings in the last 10 years for bone regeneration. Here's a patient who's a dentist. He has 2 mandibles. He says, Istvan, can you do one? Then I come back, in 3 months I do this. Okay. But this is January, this is April. When can I place the implant? I said 6 months. This is October, 6 months old. Beautiful. But cortical bone only here. Here, some Sharpie fibers. Okay? So I have to place the implant at least 1.5 millimeter deeper. Look at the other side. What happens? Cortical bone grows and the Sharpie fiber disappear. But you lose up to 1.5 to 2 millimeters of bone less. Look at the other side, 10 months old, cortical bone. Okay, see this? Sharpie fibers, baby bone, and cortical bone. The 2 phases of bone formation. So these implants, I'm going to place slightly deeper. Okay, these are the Thai ultra surface parallel implants, maybe equal to bone or maybe 0.5 millimeter. It's up to you. But this has to be deeper. You understand? If you put it to the crest, what happens if you put it exactly to the crest? You put exactly to the crest, this is what's going to happen. Doesn't matter which brand you use. You can use Nova, Straumann, Korean, doesn't matter. It's biology. Biology doesn't care about the brand of the implant. Two things. Another thing. If the soft tissue was very thin, that's also a problem. That's also a problem. Okay? So what do you want? What do I do with this? Honestly, it's my case. I screwed up. You know, sometimes I'm stupid. It was like 10 years ago, but I screwed up. So, shall I remove the implant now? Shall I do nothing? Shall I smoothen the implant? Yeah. I'm showing you the good, the bad, and the ugly, okay? So you remember what I told you. But look at this one. Here I'm placing this implant. Actually, it's called a tissue connection. It's also a Nobel implant. Very few people ever use it. That's a very good implant. And I'm going to place it now deeper, because there is sharpy fibers here. It's a regenerated bone. It's a regenerated bone. I'm going to place it somewhat deeper. I will do guided bone remodeling. And we have done a study with this implant, and we have found 0 implants with bone loss, because they all look like this. Okay, so you can do a bone level implant deeper. If I put a bone level implant deeper, I put an on one abutment or a multi-unit abutment, and I don't touch it anymore. Or I put this implant, which is not very well available anymore, deeper. And we tested all the brands. Tested all the brands. This is a Swiss brand. We did the same thing, but nobody's using this implant, but we tested because they had like this type of design, and we found the same thing. So we can do deeper bone level or this type. Here you can see a patient in the posterior mandible. Look at this bone. If I put an implant here, what happens? Bone loss. If I put an implant here, what happens? Bone loss. If I put an implant, it has to be here. Because this is a pseudoperiosteum. This is not cortical bone yet. So this implant, this patient, I put a membrane, I open the flap, remove the membrane, took a histology. Is this. Then I close the flap, no implant. 3 months later, open a flap, another histology. We have ethical approval for this. Look, it's like a posterior maxilla, but it's a mandible. 3 months later, same patient. Almost 4 millimeters of cortical bone. But this part was lost. And this part, sometimes with your own eye, looks good. No, it's good. I stop here. No. Microscope. You don't have microscope. Microscope shows collagen fiber. Collagen fiber will be shredded off. Like a snake skin. Very important. Look at this. Now I place the parallel CC implant to the crest. It's perfect. Why? Because I placed the implant after the shred off. See what I'm saying? I wish somebody was telling me this 20 years ago, okay? This is how important this is. This patient has a very thin phenotype. If you track this tooth, it's so narrow, it's narrower than you place an implant. So this patient will need a bone graft. But I'm doing a bone graft, the patient never came back for 3 years. And I don't see, there's no resorption. Why? Biomaterial. In here, popcorns. Anorganic, bovine bone, mineral, xenograft. If this was an autogenous bone, no implant, 3 years, no bone. Let's take a histology of the final bone. See? Old bone, new bone. No difference. See? No difference. Originally, there's a big difference in the histology. At the end, it's the same. In my experience, this bone, after shredding off this layer, will never change anymore. Will stay for 25 years like this. Okay? But you have to understand the surface. This is like a decade later. Very old style Brenner mark implants replaced. They don't really exist anymore. So what I recommend you to do is this. I remove the membrane. I look, there is a pseudoperiosteum, pseudoperiosteum, layer of soft tissue. Okay, no problem. I remove it. Then I take a curette, and just shovel off anything which is like in the soft tissue to resurface. And then I put the implant deeper. Okay? But let's say the nerve is still very close and I cannot put the implant deeper. If I cannot put the implant deeper, I'm going to do a mini bone graft on top of the implant, a mini sausage. Okay? Because if I stop in the crest with my implant, I will lose bone. Because this is not the final bone. See, let's take a CT scan. This is a mixture of autogenous bone and a xenograft. And this is at, I think 13, I have 18-year follow-up on this. It's not shrinking, not going anywhere. So, what I want to tell you is not this yet. Yeah. Oh, that's good actually. Okay. The membranes. What type of membranes do we have? We have collagen membranes. We call it a sausage when we do horizontal augmentation with the collagen. See, it's a lot of graft, but I'm putting only a collagen membrane and stabilizing the membrane with pins. Or, for vertical and horizontal augmentation, I put a PTFE membrane, which can be titanium reinforced. This is dense PTFE. Or you can do titanium mesh. Titanium mesh, we also call it the titanium mess. It's not easy to remove. It has about 20 to 25% of exposure compared to this, which has almost no exposure today. The PTFE membrane has two layers. One, an internal layer, and an outer layer, which is dense. Why is it dense? So bacteria cannot penetrate. If you have a little exposure, it's the best membrane in the history. Titanium can osseointegrate and biocompatible. This can osseointegrate and is biocompatible. See this? Osseointegrated. This membrane is very, very, as biocompatible as titanium. It has different thickness. 150, 200 and 250. I don't use the 250 anymore. I use a 150 or a 200. So, first before this, I want to talk about the sausage technique a little bit, okay? So I'm going to go down here. Okay, that's the first technique. It's the most private practice friendly technique that you can have. This picture was taken in 2004. In 2004, I told my friends that I'm going to do a widening of the bone with a resorbable membrane. You know what they said? This is the most stupid idea on the planet. There's no way you're going to get bone. So, first case. Here's the bone graft, sinus and a horizontal augmentation using a resorbable membrane now. Very easy to use. And we got this. Now, how long is this going to last? This is at implant placement. 1 year, 5 years, 11 years, 15 years, Brenner mark implants, 15 years CT scan, 19 and a half years later. Still in there. Here's another one. Native collagen membrane. Let's take a look. This patient have 3 teeth, but she doesn't want them all on 4. She wants to have crown membrane, so we do 3 kind of like minimally invasive surgeries. Okay, we're going to go and the posterior mandible bone graft. Open this up. Okay, I'm going to fast forward because we'll talk more about the mandible. Here it is. That's on the lingual side of the flap. I'm going to talk more about it after the lecture. As you can see here, the dense connective tissue. That's the lingual flap. Very clean teeth. I'm going to scrape some bone. It's narrow ridge. It's a bone graft which is autograft and a xenograft mixture. I'm going to perforate through the bone. Then I fixate the membrane on the lingual. Okay, now but this bone graft is going to move, so I need to stretch out the membrane. Stretch out the membrane. Stretch it out and push up the bone graft to the top of the crest. That's why we call it a sausage, because we really stretch the membrane, stretch and compress the bone graft all the way out here. Then one more spinal stretch. And then I'm going to advance the flap on the buckle. This is around the nerve. I'm going to go around the nerve. Debundle around the nerve. Very superficial, so I don't damage the nerve. Now I'm going to stretch the flap, pull it all up, put it on the side, stretch it all up, and I can close the flap. Okay, once I close the flap, we're able to place the implants into the newly formed ridge. You can also see them here. Here's just a quick, I'll just show you how thin this is. Look how thin this is. Fast forward is a dentist. Look at that, paper thin bone. I just want you to see again, how we fixate this membrane. This is the mylohyoid muscle. Very clean tooth, very good crown. Temporary, but it's good. I'm going to scrape some bone from here. Use a scraper. 2 minutes. Some autogenous bone. I mix with a xenograft. Perforate. Mix with a xenograft. Fixate one on here. Fixate another one over there. This is a native collagen membrane, it's not cross-linked, like a bioguide membrane, this one is. I'm going to put all the bone graft in here and stretch it out. Okay, so this one, I'm going to stretch over here. Here the bioguide is very flexible membrane. You need something native and flexible. And we're going to put this in, anorganic bovine bone mineral, 50% autograft. Fixate the bone graft up to the crest. Then stretch a little bit more, fixate one more. This is what we call the magic pin, which does the magic. And then we're going to close the flap. Okay, I'm going to come after the lecture, I talk about how to close the flap more. Okay, but let's go back and see what happened. You come back down here, and I will have, in this particular case, I will almost have like cortical bone already. These are the master pins that we use. I'm not sure if it's available here, amazing, the pins. Bleeding vital bone. And you will not get a resorption from this ridge anymore. Okay? There is a very young, very old lady. She says, "Doctor, I have osteoporosis. How's going to be my bone?" I said, "This will be the best part of your body." I was just kidding, but she was laughing at it. So anyway, look at this. This video is 2012. I'm going to show you the follow-up today. 2012. Very thin ridge. Okay, I'm going to do the same thing as I showed you. So I'm not going to show you the whole video, but please look at this. Now, here's the bone. This is baby bone. I'm going to place 3 implants. There it is. These are 5 years. These are 10 years. Brenner mark, tiny 19 implants. The best part of her body is this bone. So we have many sausages. I always say that this technique is your private 85% of your cases you can do with a collagen membrane. But you have to stretch. There's an article, new article shows a French oral surgeon who only saw me doing it on a lecture, and she did it, and then she took the course. And she published the cases before and after, and it's a big difference between the two, actually. So it's a little bit of a technique you have to learn. But look, less invasive in less time. Live surgery in 23 minutes. I was doing the live surgery, okay, it's almost finished, what shall I do now? In 23 minutes. More mature bone, why? Because the collagen membrane lets the vascularization through the membrane. Look at that, it's more than 10 millimeters wide. Less invasive, easy implant placement. I showed you this little video clip, very easy to place the implant because bone quality is usually very, very good. Okay, so, yeah. I really like these drills. I think one of the strengths is you have to have very good drills, and this company is very, very good kits, drill kits for sure. Okay, so there's the implant, right? Okay, look at this. Very thin posterior maxilla. Very well stretched membrane. So much bone I could place 6 implants. 1, 2, 3, 4, 5, 6 implants. Okay, but I only did 3 because patient was poor. 5 years, 10 years later, bone is perfect. Why? Because it's biomaterial and the xenograft. That's the result. 10 years of follow-up. Look at this one. So it's huge. That's the 2010. That's only the 8-year follow-up. Look at this. I'm going to show you the 13-year follow-up now. Here's one bone. Here's the perfect bone quality. 1 year. 5 years, That's 10 years, sausage and sinus. 13 years, sausage and sinus. 8 years, the sausage. CT scan. The bone stays. It's not like the autograft. Doesn't resorb. You can do some vertical augmentation with it. Small one, but as you can see here, I extracted this, so I've done some vertical. This is at 10 years. I think follow-ups are very, very important. And yeah, this is sinus and sausage. I formed the papilla for the anterior maxilla. We use zirconium today, but this is a 15-year-old case. So now it's very hygienic. You have the pontic. This is at 1 year, 5 years, 10 years. This is the smile of the patient. Yeah, usually I just place 6 implants today. At that time I've made it perfectly to the crown, okay? But this is at 5, and this is at 10 years later. Okay, so this is the sausage. This was my introduction. We're gonna take a break. This was my introduction. And I think this was the most boring part of the day. It's going to be much more interesting now, but this was important. What did we learn? What did we learn? Number 1, before you do anything, you look at how is the basal bone, narrow or wide. You look at the angulation behind the last tooth. If the last tooth is a premolar, the bony peak is lost. The premolar has a root canal, this problem, that problem, perimetral radiolucency, take it out. Okay, especially if it's steep. Then we looked at the 2 phases of bone formation. The baby bone and the cortical bone, between the Sharpie-like fibers. You're going to lose 1.5 to 2 millimeters of bone because of that. So you put the implant deeper, or you refresh and do a mini sausage. Okay? And so then we learned that different membranes, collagen, native, sausage. Your best friend is the sausage. If you learn the sausage, 85% of your cases are finished, done. You can touch the tooth, there's no removal, almost very little complication to no complication, very little amount of complication. But we have the PTFE membrane. PTFE membrane is a beautiful membrane, very biocompatible, but you need even more education for that. What is the indication? Collagen for horizontal and very small vertical, PTFE for horizontal or very large vertical. With the PTFE you can reconstruct anything. What do you need to get bone? A good graft that doesn't move and you have the flap that is closed against bacteria. And you will get bone all the time. What is a good graft? At least 50% autograft and a 50% xenograft. Why xenograft? Because it doesn't resorb. Because in a narrow patient, full autogenous bone graft will resorb. Too narrow. Genetics is a very important, and I know in Vietnam, you have a lot of narrow patients. Okay, so narrow patients, you need to buy material. Okay, we're gonna take a break now. We're gonna take some questions, not now yet, okay? In the next part, come back, because it's gonna be